Okay, questions about using the handheld dynamometer. So the post that I made where I had the ACL patient, I was talking about how you don't need to waste your time setting up e-stim and having somebody sit there on e-stim for 8 to 10 or 15 minutes doing quad sets and straight leg raises with e-stim. Why? Because you have the ability to reverse neuromuscular inhibition, which is what you're trying to do with e-stim, and you're spending a lot of time getting slow results when you could do it a lot faster by doing 180. So in the demo, I had my patient do basically a straight leg raise against the handheld dynamometer for a pre-test to get baseline measurement, which was 26.6 foot-pounds. So we're testing rectus fem. We're not testing vastus intermedius. We're not testing vastus lateralis, medialis, genu articularis. We're not testing any of the other quads. We're testing rectus fem, which is what you are trying to facilitate when you're doing a straight leg raise. So you notice I just talked about all those muscles individually, because if you are doing manual muscle tests that you learned in school that were based on Kendall's work, you are not testing individual quads. You are testing knee extension and mostly vastus intermedius. So when you take the membership and you learn how to do 180, you learn how to individually test every single one of those muscles. So that's an important fact to remember here. The other thing to remember is that when I am using this and I'm doing my demo, I am not testing gross muscle strength. I am not doing a manual muscle test. I never do manual muscle tests, because what you learned in school for manual muscle tests, so let's go back to Kendall's work for knee extension, which is intermedius. What position is the patient in? They're sitting, they're in weight bearing. They're already in the position that you're going to test, and they put themselves in that position. So when you're doing a manual muscle test, especially if you're having the patient raise their arm and do this kind of stuff, and then you're doing a manual muscle test, they've already compensated. So they've already done what they need to do to get into the position. The muscles that are inhibited didn't do anything because they're inhibited, or they didn't do enough to do what they need to do, which means the other muscles overcompensate and put themselves in that position. So you're not testing that muscle's ability to facilitate. You're not testing individual muscles. You're testing a movement pattern and how well that patient compensates in order to pass that test for gross strength that you are giving them. When we do neuromuscular facilitation tests, we are not testing strength. We are testing that muscle's ability to contract on demand. We are not letting them put themselves in the position so they already compensate. We are passively putting them in position. So when we test delts, we don't do it in standing or sitting. We do it supine. So we put them into the position completely relaxed. Then we give them force to see if they can contract on demand. We're not trying to grade them 0 to 5 and see how strong they are, because I don't care how strong they are. What I care about is, can they facilitate a contraction with the muscle that should be facilitating in that position, or do they have to compensate and rely on a different muscle? So in the video yesterday where I'm testing quad rectus fem facilitation with the handheld dynamometer, I'm putting her in position and then I'm pushing down. I am matching her pressure. I am not trying to break her. This is not a manual muscle test. It's not a break test. It's a facilitation test to see if she can contract on demand. So I am matching her pressure on the first test. She pushes 26.6 foot-pounds. I push 26.6 foot-pounds. So I'm just doing an isometric test. So that's when I show you the test. I go back. Now, what am I doing when I'm poking around on her? Why? Ask yourself this. Don't ask yourself what I'm doing. Ask yourself why she had less foot-pounds of pressure the first time. Because she can't facilitate at a normal amount. So she can only facilitate as much as her body on a neuromuscular level is going to allow her to facilitate. So when I go to poke around, what would reverse neuromuscular inhibition? Isometric or concentric contraction? No. Eccentric contraction? No. Correctives? No. E-stim? Jury's out. So what I'm doing is I'm going to the neuromuscular junction, which is responsible for neuromuscular facilitation. So if she's inhibited because of neuromuscular physiology. Here's what you don't understand because you didn't learn this in school. You don't understand how to assess and reverse neuromuscular inhibition, which is what I'm doing on that test, which is why people are posting, well, it just looks like you're doing da-da-da-da-da. Okay, it looks like I'm doing da-da-da-da-da because you didn't learn how to apply neuromuscular physiology in school. So since then, you've been reaching for things like e-stim and correctives, which does not work. So what I'm doing is I'm going to the neuromuscular junction of the rectus fem, which I just tested, and I'm irritating the neuromuscular junction to facilitate contraction of the muscle. So I'm going to the proximal and distal muscle belly because that's where the neuromuscular junction is. That's where the muscle spindle is. That's where I'm going to go. I'm not going to the trigger point because trigger points don't exist. I'm not going to the muscle spasm. I'm not going to the painful spot. I'm not going to the origin or the insertion. I'm not going to the GTO. I'm not going to the tendon. I'm going to the neuromuscular junction in order to get to the muscle spindle, which is in the muscle belly. So once I irritate that, I go back and I retest. And guess what? Her force output increases by about 140% in 10 seconds. Now, can you do that with e-stim? No, you can't. By the time you walk across the room to get to the e-stim and walk back, I've already done more than you're going to do in the next 10 to 15 minutes. So why aren't you doing this? The reason why you're not doing this, the reason why you don't know how to assess neuromuscular facilitation versus inhibition is because you didn't learn that in school. You learned manual muscle tests, which don't tell you really anything. And you didn't learn how to apply neuromuscular physiology. So if you would have learned that, you would do the same thing that I do, and every PT across the board would be doing the same thing that I did because they would be basing their evaluation and treatment processes on science rather than 1970s old school garbage PT. So these are the things that you did not learn in school. So this is why it sounds so foreign to you when you hear me talk and see me treat, because your brain wasn't programmed to think that way. Your brain was programmed to do what they told you to do in school, not to think about what you are doing and why you're doing it and what the implications of your thought processes are. That's why it's called the 180 system. It's the exact opposite of what you were told in school because we teach you how to think and we teach you how to apply science, which is why you don't understand what's going on when you see me do this. So to answer your questions, yes, I'm pushing harder the second time. Why? Because I have to match her pressure. So the first time, I'm pushing 26.6 foot-pounds because I'm matching her pressure. The second time, I'm pushing 36.9 foot-pounds because I have to match her pressure. If I don't match her pressure, she's just gonna move all the way up and do a concentric contraction, which is not going to tell me anything here. It's not going to tell me anything about neuromuscular facilitation. So when we do our neuromuscular facilitation test, it's an isometric. I'm matching their pressure. If they can't push and it stutters and gives out, that tells me that muscle's inhibited. I need to reverse the inhibition and then go back and immediately assess that muscle again to see if it's got normal facilitation. So take home message, manual muscle tests don't work. E-stim is unwarranted. There are much better ways to do what you're doing that are based on science that you did not learn in school, that you are not going to learn from a mentor unless they were trained by me, because I have the patent on this, because for some reason I'm the only one that took the time to figure out how to do this stuff, and now I'm teaching it to you. So you can either take this information and say, yes, I want to be an elite physical therapist that does things that make sense and not waste my patients' time and give them real results and get the clutter and confusion out of my head. Or you can say, that doesn't make sense. I'm sticking with the broken medical model. I'm completely happy with being average. I'm completely happy with my patients not getting any real results as long as they feel better, because as a physical therapist, my job is only to help people feel better. And as long as they feel better when they leave, then I did my job, even though they come back with the same problem 2 days later. So make up your mind. Do you want to be elite and break out of the conventional medical model and actually apply the knowledge that you learned in PT school? Or are you happy being average and soon to be burnt out and soon to be selling insurance and not using the information that you spent 7 years and 6 figures to gain? When you're ready to break out of the model, hit me up and I'll get you in the shift.